Okay.
1 o'clock.
I'm going to call the September 7th OEBB board meeting to order. In your board packet on pages 3 through 5 are the minutes from June 1st, if you'd be so kind as to look them over. Oh, before we do that, I should take roll because I can't actually see everyone. So if you don't mind letting me know you're here. Tom, you're here.
I'm here.
Bob is here. Reed, I see on my screen. How about, and Susan, Ricky Smith, I see. How about Susan Miller?
Here.
Great. Bonnie?
Here.
Great. Bill is not here for obvious reasons. JJ?
Here.
Okay. We are all here. So if you can take a minute or two to look at the minutes from last time, I'll entertain a motion to accept the minutes whenever the right time is.
Move to approve.
Okay, JJ has moved to approve.
Ricky Smith, second.
Okay. All in favor of approving the board minutes from June as written, say aye.
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 Any
Aye.
opposed? All right, we've done that. All right, so welcome back to 21-22. I'm hoping it's going to be just as fun as last year. So with no further ado, let's go on to the director's update. Ali, are you ready?
Thank you so much, Robert. Hope everyone had a wonderful, safe, healthy summer and ready to kick off this new school year. We planned for a little bit shorter board meeting today, kind of ease everybody back into it while you get the school year started. And but there will be a lot to cover in the coming months prior to starting the 2022-23 renewal. We have been working over the summer to fill our open board seats. We currently have Bill Grott's seat, Sheree Moss-Anderson's seat, and Reed's seat in the near term. And we also have our local government labor seat open. We believe we have candidates for 3 of these seats, and they'll be filling paperwork out and going through the Senate confirmation hearing in the fall. In the meantime, we talked a little bit this morning at CIAO about hopefully our new board members, since it takes so long to get confirmed by the Senate, can attend meetings as non-voting members. So Rose has also been working on a new board member orientation book that we will walk through with each new board member, and it contains things like a detailed outline of the annual renewal process and what happens after renewals, among many other things. And once we get that done, we will share it with the entire board, but we really hope it'll help new board members especially hit the ground running. We all know how it does take a while, but as much as we can help them through that process. We do have an opening on CL currently. Tom, is there anything you want to say regarding that opening, or should we just kind of open it up? Might be on mute there, Tom. Well, I will say, you know, it is really the kind of preeminent committee to serve on, and you know,
I'm off now. I'm sorry.
Oh, that's okay.
My computer's stuck. There also is, I think, someone who is not muted. So if everybody could check their mute button, we're getting some heavy noises in the background. Thank you for calling it the preeminent committee. It's a lot of fun. It doubles your time in terms of a board meeting, in that we usually start at 9 in the morning and go to 12. I think it's helpful to have new ideas, but it's also helpful to have people who know the issues that we've been discussing. So we have only 3 members on the group now. I think we can go up to 5. It'd be great to get a current board member to join the group, and it'd be great to get one of the new people to join. So I encourage current board members, if you have interest in getting into the weeds of the conversation as compared to the 10,000-foot level, join us on the Tuesday morning. And I guess you'd talk with Robert about joining the CIAO group if you so choose.
Are there any questions for Tom or Robert regarding CIAO? Okay, like Tom said, if there's any questions or you do have interest, please contact one of us or all of us, and we'd be happy to respond. Next, we have our consultant RFP. It's in the final stages of review by the DOJ and our contract oversight agency. So it should be out on the streets in the next week or two. We're really trying to push that through as quickly as possible. I know it always takes longer than you expect, but that should be out in the next 2 weeks, and we'll let the board know. We do have a new school district joining OEB for this plan year, and that is Three Rivers School District, which is down the Grants Pass area, JJ's neck of the woods. So we're really excited to welcome them into OEB. It looks like, you know, a fairly decent size school district. So we really know it'll be a win-win situation. So we are starting to receive really an unprecedented amount of interest from local governments. Hopefully you'll know, local governments, cities, counties, and special districts are eligible to join PEB and OEB. We're really seeing an increase in demand. I think there's many reasons for that. And we had an opportunity to add a position to support that demand in the legislative session, and it made it all the way up to the final full Ways and Means Committee, and it didn't go through, unfortunately. But we do have an opportunity to add that position through another means of getting resources. So what that position would do is really act as a marketing representative for OEB and PEB. It would also act as a licensed agent to assist entities with their plan selections for OEB and contribution strategies, as well as help beef up our communications. And just it's pretty significant workload to onboard a new entity, a lot of systems, communications, porting from one carrier plan to another. It's a fairly significant workload. So we're really excited to add that position, and yeah, we really believe it'll really help our communications with our members overall as well. So will help fill some gaps. And then lastly, the new joint PEB and OEB Health Committee kicked off in August. Tom and Sue Ricky Smith represent OEB on that, and we'll talk quite a bit more about the committee's work and what their short and long-term plans are at the next board meeting. But we're really excited to really get the board focused back on health equity. It's a really driving force within the health authority. And, you know, I think, you know, as we talked about in CIAO this morning, it's really something that will drive board and committee members to do their business differently, to really have that as the focus of every policy decision or every benefit decision that they're faced with. And we're really excited to have those conversations and provide the tools to make good, solid decisions where there's no disparities that would not be uncovered by that process. So with that, that's all I had. If there's any questions, I'm happy to take them.
Okay. Any questions for Ali?
Yeah, this is JJ. Hey, Ollie, is there any help that you need from anyone on the board in order to facilitate the execution of getting that new position?
No, actually, just by taking board action, I think it was probably over a year ago, is really all I needed. Usually that is all that's needed with the legislature as well, but you know, these budgets are built, you know, a year and a half in advance, and sometimes there's no rhyme or reason why we wouldn't get a position because we're not tied to the general fund. So, but I do appreciate it, and I'll definitely let you know if we could use that. Any other questions?
Okay, thank you, Ali.
Thank you.
Next up, we're going to discuss vaccinations, and I do believe Jenny and Mark are going to start off, if I'm not mistaken.
Yeah, happy to start off. Actually, I don't have, well, I think Mark is on the phone, but really who I have with me is Dr. Patricia Toro. So Ali had asked us to provide not only just a OEB specific COVID impact on, you know, the cost utilization like we've been doing at past board meetings, but just to spend, you know, 5-10 minutes talking about what's happening nationally with COVID, and then maybe more broadly in Oregon, just to provide some context as the carriers do their specific updates, and as we get into the financial specifics for OEB. So I invited Dr. Toro. She'll introduce herself in just a minute. Many of you on the board may remember meeting or listening to Dr. Louis Dickey, who has been our consulting physician for OEB for a few years now. In particular, he has been working with us on the Innovation Work Group and the Center of Excellence program. Dr. Dickey just retired in August. And so Dr. Patricia Toro is graciously and is excited to take his place working with the board and also on the Innovation Work Group. And she's been working with us alongside Dr. Dickey for the past couple of months now, at least on the Center of Excellence program. So she's getting familiar with OEB. So I asked her to go ahead and just introduce herself today and give you a quick 5-minute update on where we are with COVID.
Great. Thanks, Jenny. I'm glad to be here today. My name is Patricia Toro. I've been with Willis Towers Watson just over 3 months now. My background is in adult infectious diseases. I have a master's in public health, and I've done some teaching at Mailman School of Public Health in Columbia University in New York City, as well as worked with health plans and with providers in the past. So glad to be with you and to be working with you and sharing this update. Can we move forward? One more slide. Great. Okay, so where are we with COVID? As I'm sure everyone's heard, the cases are increasing across the United States. When I made this slide last week, we were at a 7-day moving average of 149,000 per day of new cases. That's up to now really 158,000 per day at the 7-day moving average. That's about 16 times higher than where we were in the low point in June of this year. So quite a big guess. So we're essentially going through a surge. Next slide. In Oregon, the situation is, I'm sure as you well know, is also increasing. So the red line there is a 7-day moving average of new infections or cases. The yellow line is hospitalizations. And what's interesting is a couple of points. One is that the new infections and hospitalizations are higher than the winter peak, but also too that we're seeing infections rising and the hospitalizations going up quite a lot. And the hospitalizations are generally considered a lagging indicator. In other words, they'll be going up for 2 to 3 weeks after the infections start to come down. So we, in the very short term, over the next 2 2 to 4 weeks, we're probably going to be seeing increasing hospitalizations in the state. Next slide. There is some good news. The vaccination rates are improving. This is the national picture in this slide. Daily average is about 900,000 vaccinations per day. About 1 million of those doses since mid-August are the additional doses that the immunocompromised or some others may be taking. The overall, there's a little typo in the bottom there, but basically about 53% of the total population has been fully vaccinated, and it is going up overall between new starts for vaccines and people who are getting their 3rd dose. Next slide. There's a similar picture in Oregon where we're seeing an increase overall, especially in July and August. And Oregon is already starting off at a higher point in vaccination than the national rate, with 72.3% of those 18 and older have been fully vaccinated. So that's great. Next slide. The vaccines remain very effective against hospitalization and death. Where they seem to be falling slightly short, frankly, is around new infections or symptomatic disease. So on the left there, you can see each of those lines represents a study showing pre-Delta to time points to Delta time points, so the spring to the summer, basically, of this year. And you can see that the vaccine effectiveness has gone down quite a bit for infection or symptomatic disease, but for hospitalization or severe disease or death, the effectiveness has remained fairly high. The U.S. is likely to recommend some booster shots later this month. On September 17th, there'll be a meeting of the Advisory Committee on Immunization Practices, and hopefully they'll be having a vote talking about their booster recommendation. Sorry, I don't know if you can hear my cat in the background. The immunity wanes over time, so it'll be important to see what these recommendations are, particularly for the immunosuppressed or those who are 75 and older. Interestingly, there's still no test to determine who has an adequate immune response, and so that is a real strong area of inquiry, both for research purposes, but also for policy purposes, and knowing how best to roll out these vaccines going forward. Next slide. While the vaccines are expanding and the use are expanding, indoor masking continues to be a flashpoint in the country. About 97% of the counties in the U.S. would meet CDC criteria for requiring indoor masks. So it's anywhere that has orange or red in that graph or that picture on the right. Just most, if you squint, it's most of the U.S. States are starting to reinstate indoor mask mandates, and you can see the list there. Of course, Oregon's kind of a standout for requiring face coverings in public outdoor settings, which is unusual compared to everywhere else. And we have some states that are actually now starting to restrict mask mandates, and you can see that in the bottom list there. So from a policy perspective, the mask mandates are sort of moving in opposite directions depending on where you live. Next slide. So pediatrics, this is an important area because we're seeing a climbing rise in kids who are infected. Kids are now about 22.4% of cases that are coming in a daily rate. That a month ago, that was at 14%, and then 2 weeks ago, it was 18%. Now we're at 22%. So it has been rising precipitously. And so with schools opening across the country and people going back, there's probably going to continue to be a rise, particularly until we have some vaccines available for the kids who are 11 and younger. Next slide. So, well, this is my last slide. What might happen going forward? I think that workplace vaccination mandates are definitely going to become more common, in part because the Pfizer vaccine has been fully FDA approved for 16 and older, and also because workplaces are trying to come back to a new normal. Herd immunity is fairly unlikely at this point. The Delta variant is so contagious that you'd have to have quite a high vaccination rate or vaccination and infection rate combined. We're probably going to just have waves of infection until we get to an endemic situation months or / years from now. We're probably going to have more disruptions in the school settings in this fall as children and schools are trying both from the elementary level all the way to the collegiate level, trying to grapple with new infections and that they're having with the kids. So that will ripple out into workplace settings as well, impacting there. And then there's going to be some additional challenges probably with booster delivery, particularly in the winter. In April of this year, we had a high point of new vaccinations at 3 million a day. Some of those were new vaccinations, some were the second dose, particularly the mRNA vaccines. But so if people are getting them 8 months afterwards, so that lands in December and January, I think operationally there may be some challenges, though there will be plenty of vaccine available in the US. And then lastly, on the good news front, the vaccines still are very protective against the severe illness or death. And so we would expect death rates overall to be coming down. But if there are climbing increasing cases, then unfortunately, even with a low death rate, you're going to have some more deaths. That's my update. Thank you.
Okay, I plan next to just give you a very high level overview of how claims and utilization has changed since COVID began. But I guess before I get into that, were there any questions at all for Dr. Toro? Not seeing anybody. Okay. So thank
this
you
is
so
Tom. It was just a very nice review. I really appreciate it.
Oh, my pleasure. Thanks, Tom.
Yes, Reed.
Thank you. Dr. Toro, what is your definition of herd immunity?
Yeah, so generally herd immunity is when you have enough people who are essentially not going to get infected or who have limited response, so that they don't transmit the infection to others, right? So if a single person gets infected, but everyone around them is vaccinated or immune in some manner, essentially transmission stops at that point. And so that's herd immunity. Herd immunity doesn't mean that you don't have some cases. It's just very limited transmission. I don't think we're going to hit a point where we have very limited transmission because of the amount of number of people who are still unvaccinated and who are unlikely to get vaccinated. As well as the fact that we're still understanding the immunity, how it works with vaccination. Essentially, the higher the more infectious that a virus is, the higher your herd immunity or vaccination level or whatever would have to be in your community. And if we're approaching, we would need something like 95% of people to either be vaccinated or to have been recently infected in order to have that kind of stoppage that most people consider herd immunity. And so I think that would be challenging to obtain at this point.
Thank you.
I think Bob had a question.
Yeah, my question is, are there any variants that are of concern right now in the US that will come after Delta?
Yeah, so there's right now the Delta is the predominant variant. It seems to be very so-called fit. It's able to move through and it keeps growing. So it's almost at 99% in the latest CDC surveillance data. There is the Mu variant that I know everyone's keeping a close eye on because it seems to have this thing called vaccine escape, where it seems to be able to circumvent potentially some of the vaccine, and it's seen in some countries in South America, but we don't really have it, a lot of it here that we've seen in the US. That said, I will say that I don't know which variant will come next. I don't think I would have predicted Mu. I had another variant in mind for this summer, but another variant will dominate. We're talking about Delta today. We're talking about Alpha in March. We're going to be talking about another variant probably early next year. So don't be surprised if something like that happens.
Okay, great. Thank you again so much. I think Rose can go ahead and move to the next page. And maybe the next one. There you go. Okay. So we've been doing just a very high level impact slide or two for each of the carriers on how COVID has been or how claims have been impacted since COVID began. And I know the carriers, Moda and Kaiser, are each going to follow this presentation with their own more deep dive into their specifics, especially on vaccine levels. But essentially what we're seeing here, this is the Moda slide, and I think you have all seen maybe a version of this before, but you know, since the pandemic began, it really did have an impact on claim suppression. So if you look at that chart down below, the wavy chart, this kind of shows you the dip in claims that happened during March, April, and May of 2020. So if you could, you know, you're following along, the purple line is 2018, the yellow line is 2019, and the blue line that dips is 2020. So it was a pretty big dip during those months, but after that, things really kind of got back to typical levels of incurred claims and utilization. So there was a one-time dip, but that dip did have an overall impact. So if you go back up to those charts, at the top, what you can see is for the MODA program, on a per member per month basis, medical claims were down by 5%. And that's, you know, and that's pretty significant, especially when a lot of that happened just during those 3 months. Pharmacy turns out was actually up by 8%. Now, typical pharmacy trend before COVID had been, you know, in the 10% range. So I think what we're really saying is pharmacy wasn't as impacted as medical in terms of what COVID did. Now we showed you just the little, some emerging experience in January, February of March of 2021, and we'll continue to monitor that on an incurred basis. Of course, we also monitor the paid information every month. But so far, things have continued to be a little bit under the previous levels. And I think it'll just be interesting to see what happens in the next few months as this Delta variant kind of perhaps puts a little bit more suppression in the claims in the next coming months. Okay, let's look at Kaiser on the next page. So Kaiser, similar pattern of suppression of claims, costs, and utilization, but it was more pronounced, and it happened for a longer period of time. So you can see that in the chart down below, and then off to in the upper right-hand corner, you can see that the medical claims in 2020 are 17% below 2019, so a larger reduction. And in this case, pharmacy was also down by 5%. So again, something that will be interesting to track into 2021.
Is there any explanation for that? Why it would go down?
In 2020, well, a lot of what happened in 2020 was when there was a statewide shutdown of certain services, anything that was elective or could be delayed in those early months was. And in fact, Kaiser can speak to it when they get.
Well, specifically pharmacy is what I'm asking about.
Oh, why pharmacy was down? Yeah, that's a good question. I think we really need.
That's not related to COVID. There really weren't changes due to COVID with our pharmacy program. So that's just our overall good utilization with reductions in cost in generic medications, PMPM, and good medical management of specialty and brand medications. We're not seeing that typically across the book of business, so it's OEBB specific.
Thank you.
Okay, let's go ahead and go to the next slide. So we pulled out a couple of we've been watching three particular areas of utilization, so we're highlighting them here for you today. The first is telehealth utilization. We've been watching what's been happening with the shift in where care is happening. So on the MODA side, what you can see in that top right-hand chart is that in-person office visits on a per thousand basis are down by 19%. but telehealth visits per 1,000 are up significantly. The net overall change in visits is pretty much the same. So we've got a 1% increase in overall office visits that might want to call that no change, but really what's happening is the shift and where that's happening. On the Kaiser side, interestingly, they are down overall by 14% in terms of office visits. Kaiser, before COVID had started, had already been encouraging the use of telehealth to a bigger extent. And so members were already using that to some extent, but that just enhanced and exaggerated during COVID. And it's one of the reasons we're highlighting it is that because members are becoming more comfortable with this telehealth modality, it's really something to watch in the future as to how OEB can help encourage the most efficient place and type of care. So it'll be something that we study ongoing. On the next slide, the second sort of area that we have been looking at during the pandemic is behavioral health. So behavioral health, what we're seeing overall is up for not only just OEB, but for many plan sponsors. So a big uptick in, mental health and also substance abuse. And you can kind of see it here in these two slides. So at the, if you take a look at the bottom, the combined office visit and telehealth for both MODA and Kaiser, what you see is an overall increase. So on MODA, visits per 1,000, overall increase of 22% over 2019. And for Kaiser, it's an overall increase of 14% over 2019. And then the bar charts right above those numbers are just really showing you that, a lot of that behavioral health utilization is happening in a telehealth setting. And a lot of that is because, again, during COVID, many of the offices were not seeing folks in person, but they were offering telehealth. And also many members were not comfortable going into the office. And so they've continued the telehealth modality.
Another question, where does nurse advice line fit into this?
Those are not reflected in these numbers, but that's a good point. We should also be looking at nurse line utilization.
Could I ask a question of Kaiser? The 14% combined drop, is that COVID related, or is it also potentially not COVID related?
14% increase in combined behavioral health?
No, I wanted to go back real quick. Sorry, on the previous slide. I apologize for that.
Telehealth.
Well, it's the telehealth, and it's got the visit. It's the office on the bottom right. The office visits plus the telehealth combined appears to have experienced a decrease. I was just wondering what that decrease is.
Yeah, there's probably not a one-to-one reduction in that. I think members are getting their care met in other ways, including e-consult visits through our patient portal email system. That use has increased greatly through our e-visit program, which doesn't come through the claim system. So I don't think we're too concerned about that as an issue with that. The care is happening, and we're not hearing concerns about that.
Great, thanks.
And again, like the nurse visits isn't going to be reflected in this.
Jenny, I don't know if this is a question or a comment, but I guess it's a question, because one of the things that we have talked about is that we're seeing increases of severe health needs as people have been decreasing their preventative visits and then coming in with, conditions not being dealt with that are now a worse, state. So I guess the question I have is how are we tracking that going forward, and how are we how are the health providers encouraging people to interact with their care provider, either through telehealth or through an in-person visit, to be able to decrease the severity of those conditions that are preventable if they're taken care of early?
Yeah, that's a good question. So I'll start, and then I know each of the carriers can maybe address that in their update as well. We've been doing some regular reports in CIAO that are a little bit more extended than this snapshot. And I think quarterly we've been looking at preventive care use and how that's been changing. We really were thinking before this latest surge that we were getting back to closer to be normal. But now I guess just kind of wondering, since there has been some deferral of care and there's been, a lot of media about the hospitals being at capacity. And so, I definitely think it is something that we should continue to watch and see. But I guess I would say that we're doing a little bit more robust look at CIAO. It hadn't appeared that there was a little bit of a backing off of some preventive screenings, but it didn't seem alarming, but definitely something we should watch. Any other questions? Okay, I don't know if Moda or Kaiser was up next.
Thanks, Jenny. Sorry, would you like us to address that question right now or wait until our update?
You might as well address it now, right?
We'll go. Okay. Dr. Singh, just want to make sure you're there. But yes, we have, as Jenny mentioned, we have been doing reports to CIAO, just looking at preventive utilization. And Jenny's right that there are a lot of different areas that we have been starting to see come back up to normal. There are still some areas that we see the preventive utilization is still below, and we're still trying to catch up with that. There are a lot of different things that we do around trying to reach members and try and encourage them to go in for their preventive care and their screenings. Ways we do that, and I know I talk about this every time one of these questions comes up, but I'll go back to Moda 360, and we do have our care alerts that we have that our health navigators and our advocates have access to. And so whenever they're working with a member, they are notified if a member is missing one of those screenings or preventive visits. And a lot of those alerts are tied to the preventive care measures that we have in our contracts with OEB. And then those care alerts are also going to be visible on our member dashboard by the end of this month. So when members log into their member dashboard, if they're missing a care alert, that's something that they'll actually see and that we'll be notifying them of. And Dr. Singh, is there anything else you would like to add to that question?
Yeah, that's an excellent summary in terms of, we talked about preventive utilization there, but also the HEDIS measures. Many of them are focused on prevention and screening. And so we're doubling down our efforts to ensure we stay on top of them. Clearly for our members, regionally, nationally as well, a lot of the quality HEDIS measures are heading in the wrong direction. So whenever we get an opportunity with the peaks and troughs that we're seeing with COVID to partner with our delivery system partners, we then kind of fairly aggressively go in with our quality improvement work and committees and really try and catch up there and get some of those preventive screening and other measures up to date. So that is one way to sort of measure it and track it over time, along with utilization and volume. Some of it we're encouraging our sort of telehealth vendors as well, and a lot of the types of point solutions to also get more actively involved in as well. Thus our kind of Moda 360 pulls a lot of it together, where we see these gaps that may come from different places. We integrate that and then work directly with our PCPs to get those gaps closed. But as soon as there's more capacity in the system within clinics and so on, we want them to kind of ramp back up and start really bringing patients in as fast as possible, because we do feel that there is a disease burden that's growing beyond just behavioral health, but in the physical health side as well.
Anybody else? I just saw a hand up and then it went away. Okay, thanks.
Yeah, it was Tom. I think the biggest worry, and Reed may be speaking to this. I don't think it's going to be in the cancer screening areas. I think the biggest concern is with hospitals full and emergency rooms full, that people are having acute illness that's non-COVID related aren't going to get the care that they need. So the heart attacks and the strokes, their care is being delayed. That's going to be really, really hard to track. It's going to be location specific, where at that particular moment in time, the local hospital is being just overwhelmed. We'll see what happens in that regard. My guess is that it will not be an easy thing to track. We'll hear anecdotal evidence of tragedies.
Yeah, I can add to that, Tom. That there has been some tracking in the past. Certainly last year, what we saw was a decrease in heart attacks that were hitting the emergency room when COVID was peaking last year. So to your point, I think we are going to see a decrease in that. And because the hospitals are full and they need their ICU beds, there's probably going to be fewer elective procedures as well. So it's both the current needs, the kind of short-term needs, as well as these preventative needs that we didn't quite make up the gap from last year yet.
So Jenny, where do we proceed from here?
So I think that wraps it up for our update. So I think we'll want to hear from Kaiser or Moda next on their update.
Looks like Kaiser's listed first, Robert.
Great.
Okay.
Thank you very much. Parnell will make some remarks. We'll start with update on vaccination and testing. Then we'll go to OEBB data related to PCR testing, hospitalization, a few comments about our current care delivery environment and challenges and what we're doing about it. And then we'll end up kind of talking about some of the other mitigation strategies specific to OEBB. I would say, just to respond to that last conversation, it's a complicated time in ambulatory care when you look at our consumer perceptions. And I talk to my patients about who's deciding to come into clinic and who would really prefer not to come into clinic. It's really all over the map, from people who really expect business to be usual and are very happy to come in for routine aches and pains and skin checks, to other people who say, you know what, I would really rather not risk it in a healthcare environment, despite rationally knowing it's relatively safe with everybody being masked. They would really rather get their care via phone and phone care and video care. So it's pretty complicated what consumers want. We're able to flex with that. We have found that more people are wanting face-to-face visits, so we are increasing capacity for that. But I worry about people who are suffering in silence with potential symptoms that do have important impact, and earlier management would be better. Turning over just about vaccination, and currently 73% of Kaiser Permanente Northwest members have been vaccinated over the last 4 weeks. We're really seeing slow upticks in vaccination rates, order of 1 to 2%, really in each of our service areas and among every race and ethnicity and age that we measure. OEBB numbers are higher, with 85% OEBB employees or subscribers being vaccinated as of August 29th, and OEBB members, which includes their families, at 79%. I know this was shared with OEBB staff, but we did look at 4 Kaiser members by district and entity, and it was really fascinating to me how much variation there was with the high performing entities at 92% vaccination rate for subscribers, down to lower performing entities around 58%. I would have a call out to Tiger Tualatin School District, who really led our numbers, along with a couple of other district. So kudos to them. And really, we should be looking to high performers at a district level. Obviously, there's community factors and other factors involved in that as well for some of the districts who are doing great. Our current care delivery efforts are really increasing vaccination as the #1 thing that we can do to lower the risk of developing COVID, transmitting COVID, being hospitalized with COVID, or dying of COVID. Our current efforts are all over the map and include offering vaccination administration to our patients when they're hospitalized for other things. This week, we are sending an individually addressed PCP email via our internal care delivery email portal to all non-vaccinated members, strongly urging them to be vaccinated and providing links to help get them vaccinated. We have ongoing efforts for telephonic outreach to those who haven't been vaccinated, and we're outreaching even more over to immunosuppressed individuals who meet the 3rd vaccination criteria. We are planning our flu vaccination clinics will be ramping up in the next couple weeks. Though COVID vaccination will be available at all of those. Those are all primarily outdoor sites, socially distanced, convenient and efficient to get through, with the ability of both the quadrivalent flu vaccination and COVID vaccination if someone's available. You can get both of those vaccinations at the same time. Turning over to testing, that's PCR testing done within care delivery and hospitalizations. With the surge in August, we're seeing increased number of OEB members getting COVID vaccination, really about a 50% increase between July and August. So in August, almost 2,900, which is really about 10% of OEB members had a PCR test. Positivity rate was up to 10%, which is up from 2% just 2 months ago. We've had modest hospitalizations with OEB members with really sort of 0 to 3 in the hospital per month. However, in August, we had 11 hospitalizations among OEB employees and their dependents within our hospital or our partner hospitals. Currently, there are no OEB members needing ICU level of care. So again, just consistent with the surge, seeing high levels like we were seeing last winter. We are seeing high rates of positivity, increased need for testing, and increased hospitalizations among OEB members. As anybody who's looking at the newspaper, the Lund Report, or reading the reports from the OHA, you know the hospital environments are certainly stretched right now. Hospitalizations for COVID are up by 1/3 from last week. We feel we're reaching peak hospitalization within the next week or so. There is a possible bright spot as we're seeing a slightly lower rate of COVID positivity and lower testing this week compared to last week. This is creating obviously bed shortages, which are happening throughout the state, as well as staffing shortages. To help mitigate this, we have brought on, or Oregon National Guard has been deployed in our hospitals and are helping out in non-clinical support roles. Non-urgent surgeries have been postponed. We're using a medical ethics-based triage tool to determine which of these are best to postpone and which of those are and when to reschedule them. We've trained an ethics team to be available as needed. It has not been needed as yet to make decisions on resource use, both hospitalization and ICU care, to be deployed if needed. This is part of a community-wide program, but standing this up is quite a lift to have the ethics experts use an algorithm available 24 hours a day in our hospitals. We're bringing in traveling nurses as we can. We're accelerating recruitment and hiring of nurses and other staff, and actually bringing in a pool of non-clinical staff who are doing administrative roles to help in the hospitals and clinics where needed in non-clinical functions. We've also expanded our paramedic service, which has really been quite valuable. Our home health services in the community and with Kaiser Permanente are really stretched. So we have a mobile health unit that use paramedics, and they've been really excellent at going out when when people are sick but leave the hospital with COVID, or are able to manage COVID at home. They're able to do respiratory checks, house with respiratory equipment, draw labs as needed, and otherwise provide support. That's been a way of expanding our home-based services for our members and part of our hospital at home program. I think that's kind of where we are. I would just say the ambulatory environment continues to be complicated with a range of needs with a higher acuity as people have had health issues that have built up with some of the chronic condition management not being really being helpful, seeing people face to face to take care of that. Things like elevated blood pressure, sometimes diabetes management. It's a little bit easier to get that accountability with a face-to-face visit, along with other kind of symptomatic needs that people may have. Again, we are expanding our hours. We are increasing the number of face-to-face visits. We're continuing to really deploy all telehealth resources that we can to best take care of our members. With that, I think I'll turn it to Sapari to talk about how we're supporting our entities.
Thank you, Dr. Bachman. Just wanted to share that in addition to our regular communications with our members on COVID, our vaccination and testing updates, we also share an immense amount of resources for our OEB entities, reminding them that, for one, all members, whether they are Kaiser Permanente members or non-members, can get a vaccine at Kaiser Permanente. We also have resources and toolkits available to help support and encourage vaccinations. So for example, we have materials on a vaccination overview, vaccination safety and effectiveness, and also what to expect when you get your vaccine, and also available in different languages. We are supporting our entities with monthly communications. For instance, this last month, we sent out a communication to our entities contacts highlighting back to school resources such as planning for the next normal school playbook, including topics like mental health and well-being and COVID-19 prevention. We also provided a guide to advance students and staff health with COVID relief funding. So really helping school districts determine how to use COVID-19 relief aid and to support student and staff wellness. And lastly, sharing different webinars, upcoming webinars. The next 3 that we're having in the months of September and October include integrating movement into the learning environment, integrating social and emotional learning into PE and health education, and way to well-being for educators. So again, monthly communications to our entities and frequent communications to our members to kind of help through this pandemic. And that's all we have. Any questions for us?
Yeah, JJ.
Yeah, this is not an entirely COVID question, but I know even pre-COVID, there was a fairly substantive shortage in nursing statewide, and I know especially regionally there is. Has Kaiser done any work advocating with folks in the legislature to expand the education programs to get more trained nurses?
We've been involved in support of nursing education, including having training nurse programs in our facilities and supporting scholarships for our own staff, clinical staff or LPNs or MAs to get their registered nursing certificates. We'll have to check in about legislative advocacy, which is a great idea.
Yeah, I mean, most nurses are trained at most time community colleges. Sometimes if they want to be SN, they'll go to 4-year school, but each program graduates a set number of nurses each term. They usually have long waiting lists. They could easily expand based upon demand, but the program is designed to have X number of nurses, and that's funded through the state. So I know that whatever advocacy we can do to advocate for expansion of those programs, I think will benefit all of our healthcare systems.
Agree. Thank you. Eric and Robin?
Yes, thank you. Dr. Singh is going to kick us off.
Yeah, thank you to our colleagues there, Willis Towers Watson, Kaiser, for really comprehensive updates. Going to reiterate some of those points in our COVID updates. So unfortunately, SARS-CoV-2 just keeps coming back at us wave after wave. Now there's a sort of frequency building. It's a few months apart. As we've heard globally, 220 million cases to date, 4.5 million deaths. That's 1 million more deaths just in the last couple of months. So we're very much in the midst of a fourth wave. Nationally, 40 million cases and 650,000 deaths. Vaccinations have almost leveled off at around 63% with a single vaccine, 54% fully vaccinated. Over the last few weeks, the US has been amongst the leading countries in the world for new cases. So there's now a tenfold increase in new cases over the last month or so. Over a similar time period, all 50 states reported a large upward increase, which has only leveled in a few states so far. Hospitalizations are up several 100%. Hospitals are at capacity in many cities across the country. Deaths have also risen fast and are at over 1,000 per day using a 7-day average. Again, there is some evidence of numbers reaching a peak in some states and nationally, though this is based on just a few days of data. Mask mandates returning in many locations. The CDC has advised mask use across the country, even when indoors and even for those who are fully vaccinated. Our local picture in Oregon, 285,000 cases to date, 3,300 deaths approximately. So a large increase in cases over the last month, over 2,000 cases a day on average. Hospitalizations, deaths have risen as we just heard, and some of our hospitals are at capacity. Statewide, based on OHA's update at the end of last week, we're at 94% occupancy for ICU beds and 93% for all other beds. At around 65% of the population with a single vaccine and 59% double vaccinated. In Oregon, we're faring a little bit better than the national average, but again, have largely leveled off, unfortunately, with new vaccination rates, and that poses a significant ongoing risk. Looking at some of our OEBB MODA member data to date, we have had 33,000 members tested for COVID, around 3,300 with a COVID diagnosis, around 378 to date have had an ER visit, 115 have been hospitalized, ICU about 40 to date through this pandemic, and fatalities around 7. Variants and vaccination. So the biggest concern currently is the spread of the Delta variant. First identified all the way back in December of 2020, it spread fast and become the most dominant strain in the US and most of the world. It's more transmissible, causes more serious illness, and has a stronger ability to evade our immune systems, including the immune response triggered by vaccines. It is causing serious illness in those who are unvaccinated, including younger populations. For example, unvaccinated individuals are 15 to 20 times more likely to be admitted to ICU than those who are vaccinated, proving how highly effective vaccines are. The CDC director, therefore, referring to this as a pandemic of the unvaccinated. Children under 12 years of age are now getting infected at an alarming rate, with children making up about 15% of all cases. Many young children landing in ICU, some younger than 5 years of age. All children under 12 years are particularly vulnerable as vaccines are not authorized for them yet. Vaccination is the best possible protection against the Delta variant, and although a small percentage of double vaccinated individuals are still getting infected, we know the vaccines are highly protective and are reducing the chances of spread, serious illness, and death. It's therefore critical to address vaccine hesitancy and step up efforts to increase vaccination rates through interventions that resonate with specific populations. Vaccination protects individuals, society as a whole, and reduces the pool size within which even more serious variants could emerge. Reducing that pool would also need a more concerted effort to increase global vaccination rates from the current lows of approximately 27%. For those on the fence, though, Delta variant has been a game changer. Additionally, the FDA approval of Pfizer for all adults and those 16 years and older has helped to bolster confidence and drive vaccine uptake. Ages 12 to 15 can receive it under the emergency use authorization. We fortunately have a high rate of vaccination amongst our OEB subscribers of 79% with 1 or more doses, and around 67% overall, that number including dependents. There is a lag in data, and we don't get every single vaccine accounted for, so the true numbers for today are likely a little higher than this. It's looking at this broken down in a bit more detail then. So it's full vaccination percentage for subscribers, 75.5%, and there's another 3.2% that are partially vaccinated. The breakdown by gender, male, female, very, very similar fractions of a percent difference. When we're looking at age categories, starting at the lowest of around 55% for those who are 19 to 23, and then going up by a few percent per age category as we go to the 20s, 30s, 40s, just keeps rising by a few percent. As we get up to the 65 plus, we're at 81%. So definite straight kind of linear correlation by age, and that would reflect the way it's rolled out and kind of those who are initially considered to be at greatest risk. It does therefore mean, though, that younger folks have lower levels of vaccination, and that's really where we now need to increase efforts. Looking at the breakdown by race, American, Indian, or Alaskan natives grouped together here at about 67% are amongst the lowest, so an area of particular focus. The other data that we have for race showing fairly similar numbers there in the 70s and 80s for other groups. Within the ethnicity data, we only get bits and pieces as it's collected when these vaccines are given out, but when we're comparing Hispanic with non-Hispanic, sort of two of the big groups that we've got reliable data for, it's very similar. Hispanic at 74.5%, non-Hispanic coming through 76.3%. And a quick breakdown by geography. Southern Oregon and Eastern Oregon, much lower than the average. So Southern Oregon at 63.4%, Eastern Oregon at 65.2%. Those are the areas that we're most targeting our efforts in. When you compare that in contrast to the Portland Metro that stands out at 86%, and all the other regions at similar levels in the high 70s. So some of our strategies to improve vaccine uptake. Many teams at MODA are working to improve vaccination rates amongst our members. There are a wide variety of coordinated activities driven by data analytics, including telephonic outreach, mailings to members, integration into our workflow for case management and population health teams that are working with high-risk members, sending gap lists to some of our clinics, vaccine hesitancy and messaging, training for providers. Our website keep regularly refreshed with up-to-date information and a link to the state's vaccine site locator. And very importantly, a significant body of work with community-based organizations and public health departments on specific localized activities. In terms of other variants, there are many others of interest. Alpha, beta, delta, gamma, and epsilon are all in Oregon. We heard a bit about mu variant, which is now in most US states, but in small numbers for now. Delta is of greatest concern currently, though there is likely to be other serious variants of concern in the future. This is all driving a need for a third dose of existing vaccines, currently for the immunocompromised, but soon to be extended to a wider population. Also, vaccine efficacy is waning over time, so for now it's looking like we're going to need frequent additional vaccines. Since vaccines alone may not bring this pandemic to an end in their current form, and given limited treatment options, other public health measures such as testing and isolation, distancing, mask wearing, hand washing, etc., remain very important for COVID, and of course are effective against all infectious diseases. Thank you. Are there any questions, please?
Any questions, yeah.
Yeah, this is Tom. And this is actually, I'm trying to understand, we ended up, first, the vaccines are not charged to members because it's funded by the federal government. Both KP and MODA through, and I don't know what time period, waived co-pays, maybe co-insurance, deductibles. I'm not sure of the detail of it because I wasn't paying much attention as the numbers dropped down. Obviously, with the numbers increasing again, co-pays, co-insurance, deductibles are important. And I don't know what happens as of October 1st. So what's happening in regards to the financial impact of COVID on our members, both from KP and from MODA's perspective?
Yes, thanks, Dr. Siltabo. That's a really good question. And you are correct. We are waiving member cost sharing both on COVID testing, appointments related to COVID testing, and also on COVID treatment. So as of right now, members who have any costs accrued towards that, they're not paying anything out of pocket for that. The end dates for those are still ongoing. So come 10/1, that's not going to change. The testing will end after the state emergency period has ended. And then the COVID treatment costs will will be waived until the end of this year, so 12/31, or until the end of the federal emergency period.
Okay, thank you.
And Erica, this is Katie. Sorry, I just wanted to add one more thing with the vaccination. So under the Affordable Care Act, the Advisory Council to the CDC ACIP does recommend, of course, the COVID vaccine. So regardless of the state of emergency for the vaccines, it will always be 100% covered for members.
Thank you for adding that, Katie.
And KP Sapari?
Yes, Dr. Siltabo. Thank you for the question. And kind of similar to MODA with respect to testing and vaccinations, that will go through the end of the emergency period, which is now slated for, I think it's October 21st. However, Kaiser Permanente will continue to provide that at zero cost to the members through the end of October. However, on the treatment perspective, that actually ended, the zero cost share ended at the end of July of this year. So members will now have regular out-of-pocket costs, similar to any condition that, requires hospitalization. So and I think that's the only difference.
Okay, so for KP, the cost of hospitalization has already the copay coinsurance that is already in place, and for MODA it's not in place, and it goes at least for now through the end of 2021. Did I get that right?
You did for MODA, correct.
Okay, thank you.
Any other questions? Okay, well, thank you everyone for that. It was very informative. Okay, all right, so moving on to the next part of the agenda. And if you want to refer to page 26 in the packet on a temporary administrative rule on SB 551. And Glenn, you want to take over on that? Or is it April?
Hi, this is April. Yeah, Glenn should be on as well. Yeah, we're kind of doing this together today. Hi, thanks so much for having me. My name is April Kelly. I'm the PEB and OEB Rules Coordinator, if you didn't already know that. But I'm going to talk about, again, attachment to page 26. It should be up here on the screen, at least it's on mine, and talk about these rules briefly. And then I will just the process, and then I'll turn it over to Glenn, and he'll talk about the bill and then the subsequent rules coming at you today. So you might be aware, we currently have what's called an HB 2557 program, and we've had it for a few years. It's a program that allows for certain faculty members at institutions, public institutions of higher education, so community colleges and universities, to purchase medical and pharmacy benefits at 100% self-pay. So earlier this year in this legislative session, Senate Bill 551 came out of the session. That sort of replaces, actually not sort of, it does. It replaces our current HB 2557 program. And Glenn will talk about that in just a moment. I just wanted to talk real briefly about the process. These rules did go to a Rules Advisory Committee, I believe a couple weeks ago, made up of a variety of different stakeholders. The bill becomes effective October 1st, 2021, which is why we're asking to file these temporary, given the kind of short timeline that we have to get them up and running. We'll go through the rulemaking process as well, and then we anticipate bringing the rules back to you for approval to file permanent in December. So with that, I will turn it over to Glenn. Glenn. Can you hear me? You're on
Sorry,
mute. There we go.
I was on mute. Looking down at my paper while I'm trying to talk. As April mentioned, Senate Bill 551 was passed this session. Basically, what the bill attempted to do was to provide greater access to part-time faculty at community colleges and public universities to health benefits. By providing them, with the same access as you would be given to a full-time faculty for employee-only health benefits. The eligibility is geared around if they worked at a 0.5 level, or 0.5 FTE, excuse me, for 3 of the past 4 sessions. Some of the other things about the bill itself, it does say health benefits, but it was interpreted as really medical RX. And it is also, the bill specifically limits it to employee only. It requires the part-time faculty member select what's called a home institution. Basically, that would be a community college or university that they're working at, where they would apply to them for eligibility to participate in the program. Then the home institution would establish a process and determine the eligibility, collect and pay the premiums. The colleges and universities, they pay 90% of the monthly premium and the member pays 10%, and then they administer the benefits. As I mentioned, the reimbursement's kind of a 90-10 split, and universities and colleges can qualify for reimbursement from the Health Education Coordinating Commission quarterly. In a sense, the bill, as April said, it does replace our HB 2557 program. It's kind of the evolution of a number of versions of this in an attempt to provide greater benefits for part-time faculty who are not making it as eligible at the time to their university or college, because many times they work in multiple institutions and don't reach that 0.5 level at one institution by itself. So this was really kind of the final version. The final version, I would say, did place more on the colleges and universities in regards to the administration, determining eligibility, and also in regards to, instead of a straight state payment for the 90%, like earlier versions did require that the universities and colleges pay and then get reimbursed for the 90%. Are there any questions before I go into the specifics of the bill, or excuse me, the specifics of the rules? Okay. Basically for our rules, we try to keep it pretty simple and high level, because our role as an organization in this is really to kind of provide the benefits and allow them access to the specific plans that they're eligible for. So the number one, what we're saying here is that the eligible member who is basically who was ever deemed eligible by their home institution or Oregon Public Institution of Higher Education based on the requirements of SB 551. A member who is already eligible for part-time, a part-time member who's already eligible for benefits through their community college or university, though would not be eligible for this program. So say a specific community colleges do provide benefits already to their part-time people, even if they're not meeting 0.5. Those folks would remain in that program through kind of that stream and wouldn't be eligible for 551. They can only enroll in an employee-only medical RX pharmacy coverage. They can waive medical and pharmacy coverage but may not opt out coverage and receive a monetary incentive. Again, this is kind of where if they are already eligible for benefits or coverage, either as a subscriber or as a dependent, they cannot be eligible for the 551 program. And then OEB reserves the right to audit and retroactively terminate their 551 coverage if it's discovered. The next thing is if they miss their enrollment period and enroll in coverage, they will have the ability to appeal to OEB for enrollment. Coverage elected under this section is effective the entire plan year unless the 551 eligible member is terminated by OEB or by an Oregon Institute of Public Education for failure to meet 551 eligibility or participation requirements. These folks under the law have to be, at minimum, have to be checked for eligibility twice a year. So say for someone who is deemed eligible in September, but is not deemed eligible in March, then they would be terminated by their Oregon Institute of Public Education, Higher Education. So that way they would not be eligible for the entire plan year if they're terminated. This is, of course, standard practice within OEB for all our people. We will not credit deductibles and out-of-pocket maximums for 551 members who transfer between the OEB medical plan and the PEB medical plan. These folks, because they can also go through universities, will be eligible for PEB medical plans through there. So, but which again is kind of standard practice. We can't credit the deductibles or the cost sharing between OEB and PEB medical plans. It shall be the sole responsibility of Oregon public institutions of higher education to determine eligibility for coverage. And it shall be the sole responsibility of the part-time faculty member to submit all information necessary to the home institution to make an eligibility determination for 551 coverage. And then lastly, these folks, if they're terminated, they will become eligible for COBRA. So that is kind of the rules in a nutshell. I just want to open up for any questions, suggested changes.
It looks, does Tom, do you have a question? Your hand's raised.
When this is all.
I'm not sure.
Ali, did you have a question?
Well, I was just going to make a comment. You know, this bill is, when in April mentioned, it rapidly changed at the end of session, and this is what we would call an administrative hairball. It didn't matter who ended up with it. It was going to be a tremendous challenge to implement, and then given the timeline of just a few months, made even more difficult, and it really kind of fell in the laps of the universities and community colleges, and which we are grateful for, but we do still play an important part of this, and we've been working with a group of university, community college, HR and payroll leaders to figure this all out, and so we think we have a pretty good plan in place. We'll have to wait and see. You know, the bottom line is we hope to get as many part-time employees who are eligible to enroll and get them the benefits that they deserve and worked hard for. So that's ultimately the goal of this. And I know the administrative rules are not the clearest and easiest to understand, but this has been a long time coming. So thank you.
Do we have a sense of how many people are going to be participating in this?
That's hard to say. I will say when we, you know, the earlier versions had used the same system as HB 2557, and when we priced that earlier version, or you know, early versions, it was around 1,700, and that was an average of the past 10 years of what we call eligible members, but they really, this last version changed it and used a more, it's 0.5 FTE in 3 of the 4 past sessions, or past terms, excuse me, and also opened it up to the universities. So it's really hard to say whether it's going to be greater or less. I would say probably greater, but I would say 1,700, 2,000 maybe. That we don't have an exact number at this time.
Great, thank
So
you so
Glenn,
much. Yep, yeah.
Glenn or April, can I ask just a brief question and then we'll get to the action item?
Yeah.
So how does the funding work on that? So is the state just, funnel the money to OEB, or does it go through the institution? How is that going to work?
The money was appropriated. They appropriated $12.9 million and it was appropriated to HEC, which is the Higher Education Coordinating Commission, and who will, the universities and colleges then go to HEC and say, we want to get reimbursed for this quarter. We spent this much money on these folks. So then HEC would reimburse them for that. OEB is not involved in the, reimbursement really process at all.
So if I understand this correctly, the institutions pay OEB the normal premiums like they normally do, but then
Yes.
they look for reimbursement from HEC. Okay,
Yes.
that makes sense.
Yeah.
Okay, anybody else? All right, so this is an action item. So after you've looked this over, and if you feel so inclined, I need a motion and a second for more discussion.
This is Tom. Move to approve administrative rules.
This is Reed, I second.
Okay, we have a motion that has been seconded. All in favor of approving the temporary administrative rule as written on page 26 of the board packet, signify by saying aye.
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 Okay.
Aye.
Any nays?
Aye.
Okay. Well, it seems like the ayes have it. All right. So it has been approved. Okay.
Great.
Okay. The next segment before we take a shortish break, we are 13 minutes behind, which isn't too bad for us. So, Glenn, it looks like the post-legislative session update is going to be you and Ali.
Yes, and what I was in your board packet was really a listing of all the bills that we could have some impact on us, that we've provided, basically what the bill does, their effective date, and then link to the actual bill if you want to read it further, and then any fiscal programmatic impacts. There were really 3 bills I wanted to focus on. Is Senate Bill 551, which we've already discussed, so I can go over it again, but House Bill 2010, which is what we call a public option bill, and then Senate Bill 748. I picked these 3 out because those specifically addressed in some way or really affected OEB and PEB. The other ones are benefit bills, as well as some prior authorization related bills, and those have an indirect, of course, impact on PEB and OEB, and that's either through usually a fiscal impact or no fiscal impact. So with the bills. So again, Senate Bill 551, as we pointed out, just some context, this really was a bill that was a evolution of over 3 to 4 years of attempts to provide greater access to part-time faculty members who are usually working at multiple institutions, which is why they're not getting benefits through their own one single institution. And was really to have the state step in to help fund this and provide, increased healthcare access for them. It does become effective on 10/1. The community colleges will be doing enrolling in October, and then will retro enroll back to 10/1. The universities will also be doing enrollment in October, but will start their coverage on November 1st. There really was no fiscal impact on OEB through increased premiums. The original versions of the bills did have it because the funding would come through us. And also we had an administrative and system impact because it would have had OEB administering the program. Same for PEB. We may need an increase, we may be impacted from a financial standpoint because when the premiums flow through us, they are counted as budget expenditures. We've been, as Ali pointed out, we've been working with the universities and colleges, regular meetings to hammer out a process for this. We, of course, as you've seen, developed OARs on this, and we will be doing some communications, putting up a couple websites, and then providing some documentation for the universities and colleges to use. That, is kind of in a nutshell, and I've given you the kind of the background on the bill. Were there any other questions on Senate Bill 551?
Jeff.
Glenn, Jeff. So you say under impacts, no fiscal impact to increase premium rates, but programmatic operational impact. So is there a cost with those, and what's?
No, that's just staff participation. There's no programmatic or operational impacts that would have had any cost to us.
What's your definition of programmatic impact?
Programmatic would be if we had to change a system, if we had to change the rules, okay. Had to literally, like what we're doing right now is we're putting in a new member type for them. So, but nothing that rises to the level that's going to really require funding.
Thank you.
This is something that we would absorb, Jeff. It would be an impact, but not big enough for us to put fiscal on it.
So the summation of all of these bills, what kind of cost impact is there for all of when you sum them all up?
I have not summed them all up. It really depends on the bill and its timing for when it's impacted, but I can get back to you on that, Jeff.
Yeah. And whatever the cost is it added onto our 3.4% or included in our 3.4%?
It is included in our 3.4%. There's no exception for laws.
And I think with any fiscal impact, Jeff, we always put that message in there that we are under a 3.4% cap, and this would impact our ability to meet that cap. So.
Yeah, we always say to them that it will inhibit our capability to meet the 3.4%.
No comment. Well, thank you. I think we should know what legislative impact is on costs before we get to our renewal discussions.
Yeah, and we will know that. Actually, we can make that part of the renewals discussion. I believe Jenny, Wills Towers Watson, excuse me, will include that.
Great, thank you.
All right, Glenn, continue.
Oh, next slide, sorry. Yeah, House Bill 2010, that was and I'm gonna ask Ali to step in on one part of it for here for this bill. That was a bill that really started off in creating a kind of a public option plan in the exchange. It got changed to near the end where OHA and DCBS will develop an implementation plan recommendations for public health available through the Oregon Insurance Exchange. It then also added on for a bill which was House Bill 2018, which was sponsored by Representative Dexter, which had really created through OEBB and PEB kind of a more Kaiser-like system to develop recommendations for a regional global budget payment pilot that would apply to both public and private sector. The bill is effective on passage. The recommendations, next slide. The recommendations themselves for the public option, that's due by January 1st, 2022. And then the recommendations for Representative Dexter's, or recommendations for her regional global budget healthcare delivery model pilot are due on July 1st, 2022. And Ali, was there any kind of update you wanted to give on that?
Yeah, we're starting to work on it. People within the Oregon Health Authority, and you know, I would say by a global budget multi-payer pilot, really what that means is it would include all payers like PEB and OEBB, the insurance marketplace, as well as CCOs, and even potentially the private sector as well. And I think you could define a global budget, you know, or at least see it as 3.4% total cost of care. So that would be similar to like a capitation payment where you would pay a group of providers, you know, up to 3.4% per year to care for your members. And it would have things like quality indicators, potentially performance bonuses, potentially fees at risk, performance guarantees. And, you know, the real challenge of this report is finding or identifying the region that would have a group of providers willing to put something together. So that's kind of where things are at. I'll have a consultant to, you know, basically pull data and analyze data, and we'll be keeping the board updated on this as it moves along, and that's really about it.
And the other thing too is, you know, we should have representation also on the, you know, we'll have staff who will be participating in the development of the public option, because one of the issues that they will be looking at is how to leverage existing systems, healthcare systems, such as PEB and OEBB and others, to really keep the affordability of this plan down. The original bill had required that plans within PEB and OEBB participate in this pilot program, and also providers. So, you know, we are keeping contact on that. So, you know, and we'll have input on that. So those are the three main bills. Did you want me to go through the others, or were there, did anyone have any specific questions?
Yeah, I have one more under
sure.
HB 2623.
Sure.
I think there's I think there's a word left out here.
Okay.
It said requires health benefit plans limit cost sharing or other out-of-pocket costs as adjusted to exceed $75 for a 30
Oh,
day
yeah,
supply.
to not exceed.
Yeah.
Sorry, thank you, Jeff.
But I think we need to make sure that is expressed somehow so it's not in the record wrong. And I presume it doesn't matter whether it's generic or brand. So one of our carrier partners can provide that on a generic basis.
Yeah, I don't remember seeing anything that counted out generic.
Okay. Thank you.
Okay, so how about this? We could take our 10-minute break, and when we reconvene, if anybody has any other questions regarding the other bills that passed, if you peruse that, then we can address them then. Otherwise, we'll move on. Does that sound okay for everybody? To everyone?
Yeah.
Okay. All right, so we are at 2:36. Let's reconvene in 10 minutes, 2:46, and I'll see you then.
Okay.
reconvene in 1 minute. Okay, welcome back, everyone. Does anybody have any questions for Glenn regarding the other legislative pieces that he laid out in his very well thought out and easy to read presentation? Okay. Thank you, Glenn, very much for that. Okay. So we're moving on to Cindy with an open enrollment update. And you're still muted, Cindy.
How about now?
We had this problem at CL where microphone was cutting in and out. It seems like it's happening again.
Can you hear me?
Yes.
Okay. All right. It's the *6 on the phone. When I call in using my phone, for some reason, I have to unmute and *6. So I don't know. Anyway.
Got it.
Now
okay.
I need to go back and find what I was going to. Okay. So I am just going to give a very, very, very brief update on open enrollment. We are about a week out from closing. I know some school districts have actually closed sooner, even as early as today. So Linda provided some numbers as of 9/5. So I think that was through Sunday. We have currently 35,554 saved enrollments. And as of 9/2, so between 8:15 and 9/2, we've had 3,000 phone calls and about 2,040 emails. So I did ask staff today if there were any concerns, any trending issues with members, and they said, no, not really. It seems to be going very smoothly. So far, so good. And that's really all I have, unless you want me to extend it for another 7 minutes.
Cindy, regarding the vaccination mandate from the governor, has the customer service team fielded any questions regarding that, or has there been any confusion?
I do not know the answer to that, Ali, but I will check with staff. Maybe if April's on the line, I don't know if she's still there, she could help me answer that, but I have not heard that. I have not gotten any feedback that they've received any questions.
Okay, thank you.
But I will actually reach out to them and find out, and I can, let the board know.
Okay.
Cindy, I received an email today from a member who's concerned about the number of late hiring that's happening and the crunch that puts on people for selection. But if somebody's hired after September 15th, they're able to still enroll, correct?
Yes. Mm-hmm.
And are they given 2 weeks to enroll, or what's the amount of time they have to make that decision?
I think they have 30 days. I think it's like just like any other new hire. And so, but if they want benefits to start the 1st of, so let's say they are hired on September 15th. If they want coverage effective October 1st, they would need to do it before October 1st. So it's 1st of the following month of when they enroll. Anything else? Any other questions?
Okay, thank you, Cindy. Appreciate that.
Sure.
Okay, looks like we're moving on to our two of our, I think, 4 subgroup reports. So, Tom, are you ready for the CL report?
I am.
Okay, let's roll.
Okay, so our agenda this morning included the review of the CL charter and roster. I've already talked about the roster component. The charter, we last year included the connection between CL and groups such as the Innovation Work Group. This time, under guidelines, we added a new component, which will be, quote, apply health equity focus whenever possible to reviews and evaluations. This speaks to our interest in making sure that decisions that we make in regards to how our carriers are providing care is not just for the general good, but actually has a health equity focus that looks at our subsets that we're responsible for. One of the keys for that is something that actually was one of the bills that we did not spend time reviewing, and that's the Real D. But basically, it allows for and encourages and maybe requires, but there's some ways out around it. But basically, to get race, ethnicity, language, gender identification, disability, get that information available so that as we look at, let's say, we're going to be talking about diabetes in a minute, looking at diabetic measures, we actually know that the programs that we're doing are showing, let's say, improvement in all groups, not just 3 out of the 5. And so that if there is areas where there's ongoing disparities, we can ask our carriers to figure out how they're going to address those type of issues. So that's what's behind that guideline in terms of how CL will do its work. We talked about whether or not that should be explicit versus implicit. It may be implicit after 2 or 3 or 4 years, but for now, we need to call it out basically at every time we look at a process. The next area that we reviewed was our work plan for 21-22. That is being finalized, and Rose, I'll ask you for the next board meeting that the finalized work plan be sent out to the entire board. Please look at it. If there's areas that you have particular interest in, please get in touch with me or Glenn Bailey. We spent the majority of our time talking about diabetes care. If I'm going to now move you back to the end of last plan year, so this would be in June, we had talked about an offer that Weight Watchers, now WW, offered us of adding in a program that they are developing, which is WW for diabetics. And it involves using certified diabetes educators for the subset of people who are using WW who have diabetes. And when we obviously our carriers have lots of things going on in regards to diabetes. Diabetes is a important area of care, a chronic disease that has implications across the spectrum in terms of additional illnesses and morbidity, mortality, and cost. And if you remember, in just over this last year, part of the MODA 360 program was the addition of Livongo. And we got an update on Livongo. This is also a vendor that MODA uses, that they're now up to 19% of MODA's adult diabetics are now connected in one way or another, engaged with Livongo. The bottom line was that MODA did not want another program to diminish their effort at trying to get people connected with Livongo. Kaiser Permanente didn't have strong, if I remember, did not have strong feelings one way or another, but were not opposed to using the WW for diabetes. We had Willis Towers Watson provide us best practices for 3 different elements of diabetes care. First, the pre-diabetes or metabolic syndrome, diabetes management, and then some discussion around diabetes reversal. Probably the most important comment that was made was by Jenny Marks, who said, are more solutions better? And I think the answer was yes, if they provide something that's unique, then more is better. But if they're similar, it actually could interfere with our goal of coordination and integration with with the delivery system. And when we looked at WW for diabetics, it didn't have a very sophisticated reporting system in terms of knowing whether or not the interventions that or the engagement between the member and WW, what actually was happening. And it was, their WW's recommendation was that the members share it with their primary care person. There wasn't significant coordination. So we left our discussion with a recommendation, which was focus on our current programs before we start looking for new solutions. We'll be spending the year looking at what type of ways can we do to promote those current solutions, and we will be looking at looking back to see what's actually happening with our diabetic our members in regards to quality outcomes. We have a diabetic bundle of quality measures that are available for us to look at. We need to look back over time and continue to track it over time. And as we have new innovations, such as a Livongo for the MODA members, we have to see what impact that is having. And we also have to, as I just mentioned in regard to the health equity issue, we have to look at it from a perspective of, okay, for the groups that we're able to identify, are we finding disparities? And probably the new question will be, do we have to come up with new solutions for groups that are not responding to or been benefited by the interventions that we have in place? So I think that is, so our recommendation to the board is not to accept WW for diabetes. We'll continue to obviously have our relationship with WW for the weight management program. I'll stop there and invite Robert and Jeff to make any comments that they may have in regards to what I just said. and then we'll go into questions.
It's Robert. I think you summarized the conversation very well, and I don't have anything to add.
Okay.
I'll second that.
Okay. So the issue that that I'm asking board members, your recommendation from your CIAO committee is not to pursue WW for diabetes, and accept the fact that we will be pursuing diabetes as a chronic disease that deserves ongoing focus and attention, and we'll bring that back to the board over the next 3 to 5 months. But if the board, CIAO, if you read the guidelines, we are a group that recommends. We don't. The board makes decisions about benefits and the like. So if you want to ignore our esteemed opinions, go for it.
So any questions or comments about the direction that CIAO recommends we take regarding Weight Watchers diabetes?
I changed my mind. I want to add one more comment, and I just want to stress that we favor the programs that connect people with their primary care physician so that other aspects of the disease are attended to, where Weight Watchers was a bit more focused.
Focused on weight.
Yeah.
Diet and weight. Not that that's not important.
No.
But it's as Jeff says, diabetes is a complex metabolic condition that has multiple different best practices, and we didn't want to, that's best done in an integrated and coordinated manner.
All right. Seeing no request for comments or questions, throwing it back to you, Tom. Is there anything else from the CIAO report?
No, the only thing that I do ask people to do is when you do get the work plan, look at it, and if you feel like there's areas that we are missing, please get in touch with us. There is one more message, and that's the work plan that you'll see is what we have done from an internal basis. We are not, OEB is not alone in this pursuit of, controlling costs and improving care and outcomes and the care experience. The work of the Innovation Work Group will have impact and will probably go on and add things to our work plan. And there's some statewide work that's going on in regards to value-based purchasing that will impact us, and that will also fill out our work plan over the next year. That's it.
Okay, thank you, Tom. JJ and Jeff, it's time for your Innovation Work Group report.
Okay, well, currently the Innovation Work Group is focused on 3 primary things, amongst some others. They are Center of Excellence evaluation and development of that program. So far, we are pleased that there are a fair number of facilities that meet the minimum number of procedures elements of the profile. Further, our consultants are investigating the quality aspects of their services and also their willingness to accept the prices that we're targeting. So that's going along perhaps better than expected. I think when we talk about centers of excellence, sometimes we're worried that we'll tell our members they only have their choice of 2 places to go. But it looks like we're closer to a dozen in the state when it comes to musculoskeletal procedures, which is our first focus. Secondly, we're conducting a behavioral health network adequacy study. This is, we've kind of broken apart Lodestar, whatever it is, that program, and getting it into bite-sized chunks. And so that evaluation is taking place, and we expect to see some results at our meeting later this month. Also, the Innovation Work Group was given oversight of developing the performance guarantees that would be shared by both PEB and OEB. This is another outcome of 1067. And so those are in final development. We've looked at a couple drafts and made some changes. They're really nothing that we will see because in OEB, because we're going to have to adopt those individually as separate boards, but they just want them to be aligned so when we're negotiating with our carrier partners, they are the same as is appropriate. So did I say mental health adequacy? Yeah.
Yeah.
JJ, anything else?
Yeah, I just want to complement that and saying part of the rationale of funneling our look at the Lodestar concept is the state is doing some work that is similar, and we didn't want to be duplicative or conflicting with what the state's doing.
Yeah.
Any questions for Jeff or JJ on their work on this important subcommittee? Okay, seeing none, we have reached the end of our agenda. I do need to ask whether there is any public comment that we need to address.
No, there's no public comment.
Thank you, Rose. All right. Well, I want to thank Willis Towers Watson for all the work they did, and thank KPM Motive for all the information and cooperation that they provide. I'd like to specifically thank Rose, Ali, Glenn, April, and Cindy from the OEB staff for helping us on an ongoing basis. And thank you, board, and we will meet up again in October.
Hey, Robert.
Yes.
Good job. Nice work.
It's just another meeting.
Well, that's good. It's good work. Really appreciate your leadership.
You finished your first meeting on time. Good job.
I think this will be the only time, but thanks for making the agenda light this time. So, all right. Well, I will see all of you in October, and this meeting is adjourned.
Thank you.
Bye.
Hey, Bob.
Hey, Jeff.
Haven't seen you in a long time.
I know, it's been a while. Good to see you.